Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
What is the starry sky appearance of the liver on ultrasound, and what disease state does the starry sky appearance suggest? The starry sky appearance is a sign of hepatitis on ultrasound. The starry sky appearance manifests as echogenic fat around portal triads that stands out due to the background liver edema. Look up an image of the starry sky appearance of the liver so you are familiar with how this looks if you don't already have this in mind, and remember that this starry sky appearance should make you think of hepatitis. Next, are benign liver masses more common or less common in a cirrhotic liver? We already know that hepatocellular carcinomas are more common in a cirrhotic liver, but what about benign liver masses? The answer is that benign liver masses tend to go away or not develop and are much less common in a cirrhotic liver. Therefore, treat any liver lesion in a cirrhotic patient with some suspicion, because the cirrhotic liver is not welcoming to benign liver masses, and these masses therefore go away or else develop into hepatocellular carcinomas in certain cases, such as a very large hepatic adenoma. Next question. Carcinoid to the liver and HCC are both arterial enhancing masses. How do you tell the difference between these on board exams? Think about that for a moment, and this question applies to any liver metastatic lesion that would be arterial enhancing. In this case, I chose carcinoid because I think that is one of the more likely scenarios you may be presented with on a board exam. So how do we tell the difference between a carcinoid and an HCC on imaging? There are a few tips. First, if you see chronic liver disease, it is HCC and not a metastasis on board exams. If you see chronic liver disease, assume it is an HCC. In general, chronic liver disease is highly inhospitable to both benign masses as well as metastatic disease, so a cirrhotic liver is less likely to have liver metastases. That's really striking that chronic liver disease is such a bad environment that even highly aggressive metastatic lesions do not want to take root in the cirrhotic liver. If you see a hypervascular mass in a cirrhotic liver, it is hepatocellular carcinoma versus a hypervascular metastasis such as carcinoid. Now, if you see an arterial enhancing lesion in a non-cirrhotic liver, particularly if these lesions are multiple and scattered throughout the liver and of different sizes, and additionally, if you see a primary carcinoid tumor hanging out in the abdomen or pelvis, that clearly would guide you towards carcinoid metastases in the liver. In general, for pretty much any solid organ, metastatic disease on board exams may be shown to you as multiple lesions in a random distribution throughout the organ that are slightly different in size, because that is typically how metastases form. They don't all form in a solid organ at the same time, and because of that, you will see some larger lesions, some smaller lesions, and they will typically be randomly distributed. Additionally, they may show you a primary lesion, such as a breast mass or a lung mass, to cue you in that you are evaluating metastatic disease. Also look for local nodal disease to cue you in that a more advanced disease state is present, and use your other cues to see whether the lesion is a primary of that organ or a metastasis. Next, how do you tell a carcinoid metastasis from a hemangioma on CT or MRI? Think about that one for a moment. First of all, both of these could be seen in a non-cirrhotic liver, so you cannot use chronic liver disease to tell between a carcinoid metastasis or a hemangioma. Carcinoid will have a continuous rind of enhancement. A hemangioma will show interrupted and discontinuous peripheral enhancement. So if you see a continuous rind of peripheral enhancement, you would be led towards carcinoid. On hemangioma on a board exam, they typically would really show you the classic interrupted discontinuous peripheral enhancement. Also on board exams, they would almost certainly show you the primary carcinoid tumor in the abdomen or pelvis, along with the hepatic metastases. Whereas with a hemangioma, you would not see any lesion elsewhere. Next question. How do you tell a hepatic hemangioma from a hepatic metastasis on board exams? This is a slightly different variation on the last question where I was specifically talking about carcinoid. What about other hepatic metastases? Can these look like a hemangioma? The answer is that this can be much harder. However, look for the T2 bright signal to confirm a hemangioma. In that T2 bright signal, if it is a hemangioma, should typically be CSF bright. So you have an internal control, and that is a really high T2 signal. Metastases in the liver would not be expected to be as bright on T2 weighted images as a hepatic hemangioma. Both metastases in the liver and hepatic hemangiomas can show interrupted peripheral nodular enhancement, so you cannot necessarily use that. So in this case, the T2 signal would be your guide. Metastases also may demonstrate a thicker rind of enhancement, and you also may be shown the primary lesion, whether in the mesentery or in the colon or in the breast or in the lung, to let you know that the lesion is a metastasis and not a hepatic hemangioma. Next, what are common imaging manifestations of cholangiocarcinoma? We need to make sure not to forget cholangiocarcinoma. It is a commonly tested entity, and it has some characteristic imaging findings. Can you recall what the imaging findings of a cholangiocarcinoma are? A cholangiocarcinoma typically presents as an infiltrative hepatic lesion with delayed enhancing soft tissue that, very importantly, grows around and constricts the biliary tree and can have coexisting peripheral biliary dilatation as well as contraction of the overlying hepatic capsule. When I say contraction of the hepatic capsule, what I mean is that the hepatic capsule will look like it is being pulled in due to volume loss in the lobe of the liver where the cholangiocarcinoma is. So anytime you see an infiltrative delayed enhancing mass around the biliary tree, and you see some associated biliary dilatation, and you see that the hepatic capsule is being pulled in or contracted, you should be highly suspicious for a cholangiocarcinoma. You may also see portal and hepatic vein encasement without visible tumor thrombus, which is unlike hepatocellular carcinoma, which typically would show luminal thrombosis and vascular invasion if the portal or hepatic veins are involved. So if you see intraluminal thrombus, you would think HCC more likely than cholangiocarcinoma. That is because HCC grows into the portal vein, whereas cholangiocarcinoma narrows the portal vein from externally. If a cholangiocarcinoma causes enough biliary obstruction, you can get bilomas in the liver, and bilomas can be irritating lesions to the liver, so you could see some secondary inflammation due to hepatic irritation around a biloma. Next, what are some of the common risk factors for development of cholangiocarcinoma? For hepatic lesions, knowing classic risk factors is important. We've already covered risk factors for HCC. We've covered risk factors for hepatic adenomas. Now let's talk about risk factors for cholangiocarcinoma. Risk factors for cholangiocarcinoma include being an elderly male, having a history of primary sclerosing cholangitis, which is the top risk factor in the United States. Okay, primary sclerosing cholangitis is the top risk factor for cholangiocarcinoma in the U.S. What that means is on the ABR core exam, if you are shown a liver lesion and they give you a history of primary sclerosing cholangitis, you need to be highly suspicious for cholangiocarcinoma. Other risk factors for cholangiocarcinoma include recurrent pyogenic cholangitis, Clenorchis sinensis, parasitic disease, which is also known as the liver fluke, hepatitis B or C, HIV, alcohol abuse, or thorotrast exposure. The common thread among these risk factors, other than being an elderly male, is that these are all chronic inflammatory entities, and that chronic inflammation over time can cause cholangiocarcinoma development in the liver. Now, I mentioned thorotrast exposure. If you haven't heard of this yet, you should be aware that thorotrast is an old, no longer used contrast agent that was used, and I just had to look this up, around the 1930s to 1950s, as you will readily see if you Google thorotrast. What that means is that patients who could have been exposed to thorotrast would be expected to be at least 60 years of age at this point, if not older. And the problem with thorotrast is that it was shown to be carcinogenic and is therefore one risk factor for development of cholangiocarcinoma. We will briefly talk a little bit more about thorotrast on a future question. Next question, what is a Clot skin tumor? That is spelled Klatskin. What is a Clot skin tumor? Surprisingly, perhaps the first time I heard of a Clot skin tumor was in a board exam review for the ABR core exam. So if you have not heard of a Clot skin tumor yet, I am happy to be the one who teaches you about this first. A Clot skin tumor is a cholangiocarcinoma located at the bifurcation of the right and left hepatic ducts, which is sometimes termed a hilar cholangiocarcinoma. Okay, so one more time. Clot skin tumor is a cholangiocarcinoma that is located at the hilar region, which is the bifurcation of the right and left hepatic ducts. Clot skin tumors are aggressive, and Clot skin tumors often obstruct the biliary ductal tree, so you would expect to see a stricture or narrowing at the bifurcation of the right and left hepatic ducts on something like MRCP, and that would raise concern for a possible Clot skin tumor. Next question. Are primary sclerosing cholangitis patients at higher risk for developing cholangiocarcinoma, or are they at higher risk for developing hepatocellular carcinoma? The answer is that primary sclerosing cholangitis patients are at higher risk of cholangiocarcinoma than hepatocellular carcinoma. Next, what hepatic tumor is most associated with thorotrast exposure? I already told you that thorotrast exposure is associated with cholangiocarcinoma, but I will tell you now that is not the most classic tumor that is associated with thorotrast exposure. The most common hepatic tumor associated with thorotrast is a hepatic angiosarcoma, which is a very rare tumor, but is the most common primary sarcoma of the liver. This is just kind of one of those classic associations that is really easy to ask on a board exam, so I would be aware that thorotrast exposure is highly associated with a hepatic angiosarcoma. Other risk factors for a hepatic angiosarcoma include neurofibromatosis and hemochromatosis. Next, what MRI contrast agent is predominantly biliary secreted? I'll go through this quickly. What I am asking about is Eovist. At least historically, that has been the one most associated with being predominantly biliary secreted. Therefore, some centers have used Eovist preferentially for liver evaluation, for liver transplant evaluation, and for biliary leak evaluation. Eovist is spelled E-O-V-I-S-T. The generic name for Eovist is gadoxetate, Gadoxetate. I'm not totally sure how to say that. Let's move on to the next question. What are the two most common primary hepatic malignancies? Very straightforward question, but to repeat, what are the two most common primary hepatic malignancies? The most common hepatic malignancy is hepatocellular carcinoma. The second most common hepatic malignancy is cholangiocarcinoma. Next question. Besides hepatic cysts, what are the two most common hepatic masses overall? So this can include benign or malignant masses. Besides hepatic cysts, what are the two most common hepatic masses? Number one would be hepatic metastases. Number 2 would be hepatic hemangiomas. Next question. What are the most common primary cancers that metastasize to the liver? First, I would think of colon cancer as being the most common primary cancer that metastasizes to the liver. If you see multiple calcified hepatic metastases, you should think of mucinous tumors of the colon first and then of the ovary or pancreas. But mucinous tumors can often have calcified metastases, whether in the liver or lung or elsewhere. Next, if you see a hypervascular metastasis or metastases in the liver, you should consider melanoma, renal cell carcinoma, carcinoid tumor, islet cell tumor, thyroid tumors, and choriocarcinomas. It's good to have a differential of hypervascular tumors when you take the ABR core exam, and the most common of these are melanoma, renal cell carcinoma, carcinoid in the appropriate setting, thyroid cancer, islet cell pancreatic cancer, and less commonly, although certainly something to be aware of, choriocarcinoma. Next, how does Kaposi sarcoma, Kaposi, Kaposi sarcoma, manifest in the liver, and what clinical history do you expect with Kaposi sarcoma? The low-hanging fruit for this is that you should always look for an AIDS history for Kaposi sarcoma, as well as a low CD4 count, because the immunosuppression is typically necessary to develop Kaposi sarcoma. So if you see in a question stemming history of AIDS and a low CD4 count, you need to have Kaposi sarcoma in mind. In the liver, Kaposi sarcoma presents with infiltration of the periportal tissues and may look like biliary dilatation on non-contrast imaging. So if you see a non-contrast CT and it looks like the bile ducts are dilated and you are provided with a history of AIDS and a low CD4 count, the bells need to be going off in your brain that this could be Kaposi sarcoma. On post-contrast imaging, you then would see biliary/periportal nodular enhancement. An alternative history for which you could consider Kaposi sarcoma is history of organ transplantation with immunosuppression. Since we are on the topic of Kaposi sarcoma, how could Kaposi sarcoma present elsewhere in the body? Can you think of any classic manifestations outside of the liver? Kaposi sarcoma can commonly present with purple cutaneous plaques on the legs, in addition to the liver findings of biliary infiltration with periportal enhancing nodules. Also, in addition to the liver findings of biliary infiltration with periportal enhancing nodules, you can also see multiple pulmonary nodules with mediastinal and hilar nodal enlargement. Remember that lymphoma is on the differential of Kaposi sarcoma, and a classic nuclear medicine question is that gallium-67 would show uptake in lymphoma, but not in Kaposi sarcoma. I'll say that again. Classic for nuclear medicine board exam questions is that gallium-67 classically shows uptake in lymphoma, but not in Kaposi sarcoma, whereas thallium-201 would show uptake in both. As a reminder of my Technetium in 20 Minutes episode, if you can remember that far past, or if you haven't listened to that episode yet, check it out. I believe it's one of the very first ones I did. I believe I mentioned that thallium is a potassium analog, and therefore thallium will show uptake in tissues that have functioning sodium-potassium ATPases. You would expect that both Kaposi sarcoma and lymphoma would have functioning human sodium-potassium ATPases, and so both would be positive. So what you would need to differentiate between these is gallium-67, which would show uptake in lymphoma, but not in Kaposi sarcoma. Where thallium can be really helpful is when you are evaluating for malignancy versus either tumor necrosis or parasitic disease, because tumor necrosis or parasites would not be expected to have functioning human sodium-potassium ATPases, whereas malignancy would. Therefore, malignancy shows uptake with thallium, and entities like necrosis or parasitic disease would not. Classic for thallium would be CNS evaluation for malignancy versus radiation necrosis or something like toxoplasmosis. Final question for this episode. How do you tell a perfusion anomaly from a liver mass or a regenerative nodule? How do hepatic perfusion anomalies present? To keep it simple, perfusion anomalies have arterial enhancement without washout and are often wedge-shaped and non-mass-like in appearance. So if you see an arterial wedge-like area of enhancement, often in the periphery of the liver, you would suspect a perfusion anomaly, especially if other sequences demonstrate no mass in that region. That concludes my review of liver masses. The next episode will focus on interventional radiology treatments of liver lesions, which will include things like Y90 therapy, radiofrequency ablation, and so forth. Keep up the good work, study hard, and prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.